Welcome to the Codecast Podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello everyone, and welcome to the Codecast Podcast today. My name is Terry Fletcher. Today we are at the 188th episode of the Codecast, and today's episode I am back to our last Tuesday of the month, and that means Top 10 Tuesday to bring you the mixed bag of coding questions that I get each week that I thought you would find interesting and helpful in your coding practices. And since it's May, it'll be for the month of May, and I have had all kinds of specialty questions today. Just so you know where I get these, for those of you that aren't members, I do have a membership service. It's called the Coding Corner Membership, and it's a yearly fee, and you get unlimited coding questions answered, and also authoritative references that you can bring back to your practices, and it's something you can join on my website. So it's at terryfletcher.net, go under services, and it's the first one listed. And then I compile these questions for the podcast and just pick out the ones that are helpful, hopefully helpful to you. And I try to give an array of different specialties. So hopefully you'll find that helpful today. Now I want to apologize. I'm late on my recording, and I know my producer Joe is having a fit right now. But I have gardeners outside my office window where I'm recording, and I can hear them, and I've done this on playback a couple times, and I don't think you can, and I know Joe will try to get rid of some of that background music, but it is loud to me, and so I've tried to close everything up, and hopefully you don't hear it, but I apologize if you hear any of it. So let's go ahead and get started and see where we are at. So one of the things that is kind of interesting when I get into my coding questions is that I get questions where I have to basically do some research, just because even though I may know the answer, I also want to make sure that I have background and backup and support for my answer, because when you bring these questions back to your physicians, they're going to say, well, where'd you get that? And yes, sometimes it works when you say I got it from Terry, but sometimes they're like, well, as much as we like Terry Fletcher, we also want to make sure that our specialty society or Medicare or some published reference also, gives the same information. So number one says, how do I code for a shoulder surgery for a rotator cuff and then repair and then a removal of loose bodies? The rules for coding removal of loose bodies. Okay, so here's my answer. These are slightly different than what you would have in the knee, for example. So in the shoulder, your code is 29819. And to use that code according to AAOS, which is the American Academy of Orthopedic Surgery, and they're basically your governing body and your lobbying efforts. To use that code, the loose body must be larger than 5 millimeters. Some payers also want a separate incision, but that's a payer rule, not an AAOS or Medicare rule. And so when that occurs, then you would have the 29827 for your arthroscopic rotator cuff repair, and then the 29819 with a 59 modifier. That is permissible under this situation. Now here's one that I've been getting a lot lately, and actually once you hear this, I will also be on today's episode of Talk 10 Tuesday with ICD-10monitor.com. And I know that I'm going to be doing the burning questions that the CPT, errata, and E&M have been putting out there. And this is something that comes up all the time. And somebody posed a question to me that came from another webinar, and it was inaccurate. And I just want to explain what we're talking about. So it says, Terry, I heard in another webinar that when a physician uses an interpreter for the patient with a language barrier, during an E&M encounter, that he or she can count that as an independent historian, either under Category 2 data points with low medical decision making or Category 1 in moderate. You said you disagree, that we remember you talking in your webinar. So can you once again explain so I can show to my physician? Absolutely. So whenever you're trying to figure out how to explain something to your physician, go back to basics. Go back to the definition of what you're asking. So for example, look up the code, or look up the word, I should say, historian. So an historian by definition is, and I'll quote, an expert in history, an authoritative resource on the history of a certain time, person, or genre. Could be even a place, but that comes right from dictionary.com. So an independent historian would be somebody that would know something and be an expert on that patient's history that they may not have insight to. So what is an interpreter to? An interpreter is taking a history from the patient and relating that information or deciphering that information to English language to the provider. That's not an independent historian. So independent means that they can stand alone and they know things about the patient that the patient either didn't remember or that the patient isn't aware of. So it happens a lot in pediatric practices. And also when you have maybe a child, when I went before my father passed away and I'd take him to his doctor appointments, he would forget some of his medical timeline, when he had his last colonoscopy, etc. And so for me, filling in the blanks, that had nothing to do with interpretation. It had to do with historian and knowing his medical history. So no, you do not get a point under either category for an interpreter. Now, if it takes extra time than it would be a routine visit, you may have possibility of support if you're timing your code. So just make sure you're not using that as a data point. So a question came up about the 25 modifier. And this question actually gives me a headache because there is a misperception as far as trying to equal the 57 and the 25 conceptually. And so let me explain what I mean by that. So if the 57 modifier is used for a patient that comes into the office, and during that evaluation, that physician determines that that patient needs to have surgery, a global surgery. Well, then if it's emergent in nature within the next 24 hours, they need to add the 57 modifier, decision for surgery. Same thing that happens if they come into the hospital, so that they can protect their evaluation and management encounter and then go ahead and have the surgery as well. It's helpful if you can have two different diagnoses. So one for the diagnosis for why they came in, and then one for the diagnosis for their surgery. But something has come up on the 25 modifier. And a question came in and asked, is this the same as a decision for surgery if a patient comes to the office and our physician evaluates them and then decides to remove a lesion or a skin tag, which have 10-day globals or possibly 0-day globals? Well, the answer is no, and you'll see where my headache comes after this. The OIG work plan actually added this to their April 2021 schedule for audits, and you can find it by Googling W-00-21-35868. And what it says, and they went through and gave a narrative. It says, in general, E&M services provided on the same day of a service as a minor surgical procedure are included in the payment for the surgical procedure. The decision to perform a minor surgical procedure is included in the payment for a minor surgical procedure and must not be reported separately as an E&M service. It says an E&M service should only be reported on the same day or billed on the same day if a surgeon performs a significantly separately identifiable E&M service that is unrelated to the decision to perform a minor surgical procedure. They say in this instance, the provider should append the modifier 25 to the appropriate E&M code. Then they went on to say, and they gave a statistic, they said in 2019, about 56% of dermatologist claims with an E&M service also included minor surgical procedure, such as lesion removals, destructions, and biopsies on the same day. This may indicate abuse where the provider used the modifier 25 to bill Medicare for a significant and separately identifiable E&M service when only a minor surgical procedure and related pre- or post-op services are supported by the beneficiary's medical record. So they're going to determine whether dermatologist claims for E&M services on the same day of a service as a minor procedure complied with Medicare requirements. So I'm actually doing a review right now for a practice about this, and I'm finding that based on the OIG and Medicare definition under the Correct Coding Initiative, they're not meeting the threshold for that. They're not meeting the criteria and the requirements. So if I had a patient that came in and this patient had a personal history of skin cancer and suspicious lesions, and the physician had to do a full body exam to make sure there wasn't anything missed, to me that is a significant separately identifiable service, even though there was a specific lesion that was removed that day because that patient has a history. But let's say it's a patient who's got a couple of skin tags or a little lesion that is clearly not cancer-related, and the doctor takes it off after determining that they're going to do it during that E&M encounter. Well, according to Medicare and the OIG, you're not allowed to bill an E&M on that. I have such a hard time with that, because how do you know whether you want to remove it until the patient is evaluated? But that's the rule. So I have to give you the rule, even though I may not agree. So keep that in mind. That was a really good question that came up, because I had to research it out, because I thought, no, it should be the same as one led to the other, but it's not the same as a decision for surgery. Number 4, our physician performed an excision of excessive periumbilical skin and wants to code for a 11406 for lesion removal. That would be no. And a layered closure, but there was no pathology report and no lesion in the report. So do we have to use unlisted? Okay, so no, actually, you have an option for coding for excision of excessive skin, and it's based on location. So if this is periumbilical, this would be considered abdominal. So you'd look at code 15830, and that code says excision of excessive skin and subacute tissue, abdomen, infraumbilical, and it's called a panicolectomy. So remember, the panicle, that is the prefix on that, that's excessive skin, outer skin, and ectomy means to take off or to take out. So it's not the same as a tummy tuck, because that's different. That means you're dealing with abdominal muscles, and you're not here. This is just excessive skin. Number 5, what is the difference between pathological dislocations and recurrent dislocations? Notes indicate that the patient had osteoporosis and suffered pain from a shoulder dislocation. And she said her orthopedic surgeon treated with 3 trigger point injections, but she's stuck. So what do you code? Okay, so with this one, you're going to have to look at the underlying cause on the pathological dislocation. So you're going to have to kind of dive deep into the notes to find the correct ICD-10 code for this one. So basically, you're going to code, obviously, your trigger point injections, which would be your 20552. And then a pathological dislocation, according to AAOS, of the shoulder joint refers to a painful condition in which the bones of the joint are out of their normal position. And as a consequence of that, and I'm just kind of reading specifically, a consequence of that disease, it's not classifiable to any other code. So a pathological dislocation has not necessarily repeated itself. Though it's possible that a pathological dislocation could occur more than once, the driving factor is that the underlying cause of the dislocation is disease, such as osteoporosis. If you can prove that the dislocation is due to the patient's osteoporosis, then you would look to maybe the M24.311 section start. So that's the pathological dislocation of the right shoulder, left shoulder, or unspecified shoulder. That's where you start there. Now, if it states in the note that it is a recurrent dislocation of the shoulder, that refers to the repeated displacement of the bones of the joint from their normal alignment due to traumatic or non-traumatic events, such as possibly previous injury, repetitive strain, an inherited laxicity or looseness of the joint. Also could be because of frozen shoulder. This definition spells out that the dislocation has happened before, unlike the definition for pathological dislocation. So if this is the case and it's recurrent, then I would look at M24.411, .412, or .419, and that's the recurrent dislocation of the shoulder. So make sure that you're looking in those areas. You're going to need laterality, which means what side of the body you're on, so that you're coding that correctly. Otherwise, you could definitely be missing something there. So far, our coding questions have been brought to you today by JP Morgan Private Bank. Connect with over 200 years of experience, service, and stability. JP Morgan Securities, JP Morgan Chase Bank, privatebank.jpmorgan.com. Also check out their new venture into the healthcare space with Morgan Health. Okay, so let's keep going. And number 6, our patients ask if we can send them appointment reminders and bills via email, not on appointment cards or mailed statements. However, we are not set up for secured email. And so is this a HIPAA violation to communicate with patients this way? So the answer is yes, it can be. Okay, so you can communicate with patients via unsecured email, but you have to take the following precautions before you do. So let's talk about what you need to do first. So first, you have to make sure you've applied reasonable safeguards before electronically communicating with any patient. And that's the HHS recommendation. It says they recommend that you take every step to verify the patient's email address, including sending an email alert to the patient's address for confirmation prior to sending any healthcare messages. It also says that you limit the amount of type of information disclosed through unencrypted email. And then second, you must abide by the patient's wishes regarding this kind of communication and make sure it's well documented. So if the patient wants to use unsecured email to receive appointment reminders, you may do so, but alternatively, if the patient does not want to use unsecured email to receive communications from you, you actually have to provide an alternative communication method that's acceptable to both you and the patient. But in the end, make sure you look at the HHS advice and alert the patient of any risks inherent to unsecured email communication before you agree to it. So you can go to hhs.gov/HIPAA and then /for-professionals /FAQ. And so it just kind of explains what your role is for that. Okay, let's see. So number 7. Can a physician, it looks like we're back to the E&M question, can the physician include ordering preventative tests like screening mammograms or screening colonoscopies for age-appropriate patients in their MDM medical decision-making risk or in the time factor when leveling an encounter? So per AMA and NAMIS, which is the governing body for auditing, unless the test has a direct bearing on problems addressed on a problem-oriented visit, then simply adding or ordering preventative services do not factor into the medical decision-making of a problem-oriented visit and cannot be counted towards those medical decision-making elements or time. I am noticing that a lot of providers are trying to do that, and that would be inaccurate. Number 8, my physician wants to report a level 5 office visit with every patient who comes in to establish care, regardless if they have any active problems. What do I tell them? So I deal with this quite a bit on my audits, where I audit a lot of level 5s for a couple of clients before it even leaves the practice. So if the patient's coming in for a meet and greet to establish care and there's no current issues and the lab tests and screenings are for preventative or to get a baseline and not for active complaints or indications, then I would urge your provider to use preventative medicine codes. I know they don't always want to do that because they're not always covered, but that's the most appropriate code to use. Now, if the patient has a list of chronic conditions that need to be addressed, remember the new E&M rules, because they have not been addressed in a long while, then you may have an argument to support an E&M, not necessarily level 5 if you don't meet the time threshold. But remember, any screening or preventative services ordered during that encounter are not counted as part of either data points or the time, as it does not contribute to the overall risk of the patient's morbidity and mortality. So make sure you're aware of that, because that's very similar to question 7, where yes, you can maybe do it, but no, you can't have everything. So it's kind of like one of those things where you can't have your cake and eat it too. Number 9 says, what is the code for a 40-minute audio-only phone call during the public health emergency? Our physician wants to add a prolonged service code to a phone call code. So the current phone call code, 99443, that's allowed under the public health emergency flexibilities for an audio-only visit is 21 to 30 minutes, and there's no code that allows for more time. So the 99443 is the highest code. There's no add-on code either. And Medicare on their FAQs, and they've put it several times, they're very clear that they do not want to encourage more than the audio code that is 30 minutes. If more time's needed, then there should be either an audio and video component or bring the patient into the office. It means that they need more than what that code allows for. And then last, I want to talk to you about the vaccine administration code. So this is number 10. And this comes up all the time. So we're continuing to get that. And I know why it's coming up, because I'm seeing a lot of alerts from Medicare saying there's a new CPT code and AMA for vaccines. And this is for the COVID vaccine. So the thing is, and I know that when I went and had my first vaccine shot, I know that they said, can I have your insurance card? Well, you can say no, because the vaccine itself is free. But if you have one, if you have a card, I would give it to the pharmacist if that's where you're having it done, because they can bill for the work of the administration. So to actually talk to you and, make that shot or jab into your arm. And so the administration codes, they can report the work of that, administering the vaccine, counseling the patient, and then documenting in the record that they have. And those codes is what starts with the 0001A codes and so on. So make sure that you know that the vaccine codes themselves are not necessarily reimbursed. So the codes that come out in the 91,000 series. So 91300 for Pfizer, 91301 for Moderna, etc. 91303 for Johnson & Johnson. But what they're saying is that you can get the immunization administration. And so that's what they're able to do. And they're not getting much for that. So even though the vaccine is funded by the government, and that's why they're free, right now the actual administration is what you get to code for. So just want to be clear on that, because there's also a lot of problems right now with there's sites saying, oh, you can get your vaccine for $313. I just saw the OIG say something about that. But they increased the administration fee from around $28 to $40. So they are getting, some rates there. And you just want to make sure that you're giving them every opportunity, wherever you're getting it, to, take the time to do that. That's what I would do anyway. Do you have to give your insurance information? You don't. But would I give it to them so that they can at least bill for the administration? This is where the healthcare professional in me comes out and says, it's a lot of work to, have the brick and mortar place to make sure that they have all the paperwork printed. You have to sign a consent, make sure that, they talk to you about any hesitancy you could have, anything like that. And so that's something that I think they should get paid for. And if they're only getting $40, I let them have it. Okay. So that's my opinion. If you want to not do that, you don't have to, but that's what I would do. So I'm going to give you a personal tidbit this week. I actually found a new podcast, and I found this because I was on my podcast brunch club, which is basically a book club for podcasts. I do that once a month. And it's called an Escape That Podcast. That's the name of it. And what it is it's an escape room on podcasts. So I don't know if any of you know what an escape room is, but they before pre-COVID, they were really popular, especially in California. And what they were is you basically go to this site. It's really fun. And you basically have to figure out, almost like a game of Clue, how do you get out of, this place? And, it's a whodunit. It's kind of like a little mystery that you have to figure out in 30 to 40 minutes and then get to the end. So it's very fun, but now they have them on podcasts. And I did one of them, and I have a Napa trip coming up, as I keep mentioning, and it's a 6 to 7 hour drive from my house. So my husband, my friend Dina, and my friend Nick, and we're meeting my daughter and her fiance there, we'll be driving up, and I cannot wait to see if they like this. So that's a long time to spend in a car with people, and hopefully they'll think that's fun. We'll try to figure that out as we're on the road. But since we probably leave at 5:30 in the morning, I'll wait till they're awake. But if you're getting ready for road trips, I know a lot of states have now opened up, and I know a lot of states have taken off their mask mandate. It's just so nice to see people's faces now. And I know some of you are getting ready to go on vacation. Something to think about. So if you want to do that in the car, if you're interested in that, just take a look at it. And again, it's called Escape That Podcast. All right, everyone. For me, that's it this week. So go out and make it a great day, and I'll talk to you next week on the Codecast Podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter @TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.